Hi, my name's Akhila, and welcome to episode 1 on the brand new web series on the ethics of pharmacogenomics. This week, we'll be exploring this in the context of an anti-epileptic drug called phenytoin, known by the brand name Dilantin. Phenytoin is used for the prevention of focal seizures and generalized tonic-clonic convulsions. It has a narrow therapeutic index. In other words, patients that have toxic blood concentrations of phenytoin have increased risk of acute side effects. As such, therapeutic drug monitoring is often used to adjust doses and maintain serum concentrations within the therapeutic range of 10 to 20 milligrams per liter. CYP2C9 is one of the main enzymes involved in the metabolism of phenytoin, and variant CYP2C9 alleles are known to influence phenytoin drug levels. For example, individuals who are CYP2C9 poor metabolizers may have reduced clearance rates of phenytoin and be at a greater risk for dose-related side effects. An individual's human leukocyte antigen B, also known as HLA-B genotype, is a known risk factor for drug-induced hypersensitivity reactions. Carriers of the variant HLA-B*1502 allele are at a high risk of developing potentially life-threatening phenytoin-induced Stevens-Johnson syndrome, SJS, and the related toxic epidermal necrolysis, or TEN. The Clinical Pharmacogenetics Implementation Consortium, also known as CPIC, however, recommends the use of phenytoin for any HLA-B*1502 carrier, regardless of CYP2C9 genotype, patient ancestry, or age. So, you may be wondering, is there any benefit in testing for these biomarkers prior to treatment? If so, what are the ethical, social, and clinical implications for the individual and society overall in getting genetically tested? First, let's take a look at the current prescribing guidelines curated by Pharm GKB to be used by clinicians in implementing patients on phenytoin. The proposed algorithm is based on HLA-B*1502 and CYP2C9 genotypes and recommends consideration for at least a 25% reduction in the starting maintenance dose for patients who are CYP2C9 intermediate metabolizers and HLA-B*1502 negative, and at least a 50% reduction for CYP2C9 poor metabolizers and HLA-B*1502 negative as well, with subsequent maintenance doses adjusted based on the therapeutic drug monitoring and response. Research shows that the HLA-B*1502 variant is most commonly found among individuals of Southeast Asian descent, where there is a strong association between SJS/TEN and exposure to phenytoin. Furthermore, a more recent study conducted in Australia found phenytoin-associated drug reaction with eosinophilia and systemic symptoms in Aboriginal Australians who carry the HLA-B*5602 variant, with allele frequencies of up to 19% in different geographic indigenous cohorts compared with 0% in Europeans. Implementation of pharmacogenomic testing could result in precision medication whereby the approach for disease treatment incorporates the identification of underlying genetic etiology to allow for the personalized therapeutic choice that builds upon current clinical guidelines. In the case of phenytoin, pharmacogenomic studies allowed for the identification of a defined subgroup of patients with the aim of minimizing adverse effects and thereby increasing safety and drug tolerance in patients suffering from distinct classes of seizures. But at what cost? Genetic information is, by its nature, inherently personal, but at the same time, it is also familial and communal. Therefore, there are serious potential risks for discrimination and loss of privacy which need to be addressed when discussing the implementation of pharmacogenomics into clinical practice, especially in the case of phenytoin, as it singles out minority groups. Currently, Australia lacks adequate legislation to protect the privacy of genomic data and prevent genetic discrimination in comparison to countries like the US, who have the Genetic Information Non-Discrimination Act of 2008, which protects the genetic privacy of individuals by preventing insurers from requesting genetic information. The need for appropriate legislation and mechanisms to support the secure storage of genomic data was highlighted by the recent controversial introduction of the My Health Record system in Australia. This system is capable of storing genomic pathology reports and so presents issues related to autonomy, privacy, and informed consent that warrant clarification, as the decision to include genomic data on the system was made without public consultation and seemingly without due consideration of the unique ethical issues pertaining to genomic information. Genotyping and storage of DNA also creates the potential for genetic discrimination by employers and can have significant economic impact. For example, there is a misconception surrounding epilepsy in that it is a mental illness that affects an individual's intelligence and can lead to disability. Access to genetic information could show that certain individuals would not be responsive to standard medications and therefore represent an increased morbidity risk when this is not the case. Furthermore, the possibility that employers and insurers could have access to an individual's genetic information through medical records of family members might also affect future employment or insurability of their offspring. A national population-based electronic health record has enormous potential for furthering genomic research efforts. However, equally, a lack of transparency and appropriate consultation could permanently damage public trust and participation in the system. We also need to consider translational challenges that can occur upon clinical implementation of genetic testing within current guidelines. This can involve things like test performance as well as interpretation of test results by clinicians. Delay in turnaround time for delivery of test results indicating whether phenytoin is appropriate for the patient can delay onset of treatment and increase the risk of further seizures. On top of this, interpretation of results is not as straightforward as normal versus abnormal and requires further education of clinicians on appropriate use of genetic testing. These challenges can be overcome by educating clinicians on the appropriate implementation of genetic testing via adopting established guidelines like that by the Clinical Pharmacogenetics Implementation Consortium and standardizing genetic testing for the use of phenytoin in the identified subgroups of patients. In summary, the implementation of pharmacogenomic testing for the use of phenytoin could result in situations where the individual's medical condition can potentially be revealed to other parties and, as a result, lead to discrimination from employers and insurers. Therefore, efforts should be made to both protect patients' privacy whilst at the same time promote the pharmacogenomic implementation in clinical practice. Thank you for watching this week's episode on phenytoin. Tune in next week for more insight into the ethics of pharmacogenomics.